So I'll show you this once, and then I want everybody to have a chance to actually do it themselves. This is giant veins on this fake mannequin arm here, so it makes it a little easier. But you would use your ultrasound probe, and this is, you get into a lot of hand-eye coordination too, which is kind of interesting. That's probably what takes a while. For me, when I learned to do PICS, that was one of the more difficult things, is learning that hand-eye coordination. But you're actually going to look at your picture on your ultrasound, the arm's all draped and prepped. Actually, we can do this just to give you some idea of the real world, what it's like, you know, to access for PIC. We'll even put a little brachial drape onto the arm. So you get some idea of how what your window actually looks like when you're. This is about what you end up with. If I can stick myself with a needle here in a minute. Anyway, that's about what you get. So you get your needle. So you're looking with your ultrasound probe. And I just covered up. You're looking at your screen. You get your access to the vessel, and what you want to do is you'll learn as time goes is you want to stick as close as you can to the probe. Okay, and you want to go right underneath, because your field of vision that shows up on ultrasound is here on the tip. So that you're only going to get a certain field, so you have to stick close to the probe so that your needle enters the field of vision, okay? And then you'll see, once you look on ultrasound and see the needle actually enter the vein, you hold your spot very carefully. Let's see if this actually works on this. And it's even more fun with sterile gloves and a bunch of other drapes and caps and stuff on, but then your needle actually floats right through the inside of there. And it actually worked real well. So you float the wire in, hold your place with your needle, and you just take your wire or your needle right out.
How
And now you've
far
got,
to put the wire in?
you know, there's actually a mark on the ones that are in the PIC kit, so you have some idea about where you want to do. But really what you want to do is you want to be able to get enough access that you're not afraid you're going to lose access. So you want at least 4 or 5 inches inside the patient, because otherwise any little movement, the patient moves or you move wrong, and you're going to lose access completely. You got your wire in the arm, this is what you have, so you'd use a little more numbing medication in this case of what I usually do. And then you got your sheath. I always take my one finger and kind of guide this wire up, because otherwise it's like trying to thread a needle and it's not all that easy. And you just pop the sheath right over the top of that. I don't know if this is going to fit through the inside here. Yeah, it actually does. So I don't know if it gets in the chest skin. So there you go. And then you pull your wire out and you have your access. Actually, this has an outer and inner introducer. So that's the outer part, and then you actually have the introducer that's inside the sheath that comes out. There you go, you have your venous access, and you can do with what you want with it. You could leave this as a midline, which we don't do at this hospital, and put a cap on it and use it and go to town, or you can actually, from this point, you can float a PIC line through the inside of here. And, so everybody,
And then,
sir,
what do you do with that sheath now?
ultimately
After you
this,
put a PIC line
okay,
in it.
good question. The actual sheath comes right over top. It actually is this is not a peel away sheath, but the one we use when we put PIC lines in actually cracks open, and you can just peel the sheath right over top of the PIC line. The PIC line remains, and the sheath comes right out of the patient. So, good question. So, Kimmy, you want to try? Sure. See what you think? Be really careful. I don't want you to stick yourself. I think I got what you measured. If you don't want to, you can use ultrasound probe if you want. In this case, you can feel the vessel. So if you just want to stick your wire in it, your needle in there. Just like the difference from what you're used to starting IVs is with an IV, you kind of want to be almost like a 20 degree, or I don't know, almost level with the skin to pop it in there. And with this, you've got this much size of vessel, and you just need to, your angle is going to be completely different than what you're used to. So pop it into where you feel like you're in the middle of there. Looks good. There you go. Yeah, you got it right. The soft end of the wire goes in. Hold your needle. Don't be afraid of it, because your patient will be going to town while you're doing all this, and so you probably feel a little resistance, but it's going pretty good. And I'd go another couple inches. There you go. Now you can just pull hold your wire, because otherwise if you pull it out, the whole thing will come. There you go. Now grab the wire close to the skin. There you go. Pull it out. Everybody has a different way of doing this, but somehow securing the tip of it and sliding the sheath on. Do you need bifocals, ma'am?
Well, it probably would help if I start doing PICs like a little.
You'll be doing PICs one of these days for too long. And there's a little resistance, but hold your wire because otherwise as you advance it, you could lose a wire. Probably the worst complication or worst bad outcome is if you lose your wire inside the patient, and that has happened. And then you have to go through the groin or the femoral vein or the jugular vein to go pick it up out of the right atrium, so it's not a good thing. Perfect. Awesome.
That's easy.
You want to try one, Carmen?
Sure.
See one, do one, teach one, right? You not ready to start teaching?
Still trying to get
There
to
you
do
go.
this stuff.
How we doing on time, Mr. Malott?
We're doing good.
Okay.
I just crossed 50.
Again, you guys are, it makes me nervous to see you leave the needle there like that, because in real life, you don't want to just leave your
Don't
needle.
let go of
I
it.
know this is not a real patient, but just keep that in mind when you start practicing on real patients, that you're going to want to keep that needle. And I'm thinking it's intuitive that you'll do that, but I'm remiss in my duties if I don't say that. Is that going? You might, okay. So when that happens, when your wire won't go, you probably went a little too deep. I'm just guessing.
Going back.
Yeah, just maybe
Try it,
pull
bring
your,
back, like,
yeah,
wire.
now try it. What I do is, in real life, is
Yeah.
is I pull the wire back a little, or the needle back a little bit, and then try with the wire again. And a lot of times, I think you're going fine now, yeah. What happens is, in real life, again, you have blood return, and if you're in the wall of the vessel, or you double wall it and go all the way through, and the wire won't go, then you just back the needle out just a little bit, and you try with the wire again, and sometimes it'll pop right in.
Aren't those bags to give you flow?
That's what they're for. I don't have any idea if they actually are functioning at this point in
Oh,
time.
oh.
This arm is from 1943. You know. I'm sorry. Yeah, there you go. Now, so you initially you get your needle back out, and then you immediately grab the wire as close to the skin as you can. So perfect. You did a great job. Let's see if you can see any better than Kim. Yeah, you almost have to put your fingers, at the distal tip of each one of them to get it to. I don't know how many times I watch Dr. Voodoo, that always cracks me up. There you go, so you got your back end or wire, so you don't shove it into the patient and it become a foreign body. And you probably have to grab here to close to the skin and shove from really close to where it enters the skin. There you go. Is it going for you?
Mm-hmm.
Just doesn't, it's not natural. It's one thing, it's not natural as a
How
nurse
far
to
does
push
that
things
go
that are good.
again?
All the way. You bury it, you have that bad boy. There you go, perfect.
No, this feels like it's.
Is it boogered up? Yeah. That's okay, and that does happen sometimes. Let me see.
Yep.
Yeah, just definitely get curled up in there somewhere. So, and honestly, if this happened in
Let's
real
see
life, yeah, and you hear the patient complain, I just pull, you DC the whole thing and just hold pressure. You know what I mean? So
See what it looks like when it comes out.
it's a little boogered up. I've seen much worse. A little boogered up, yeah. Probably that soft tip, it just curls up. You know what I mean? If it doesn't have
Put it
a
in
captivation. You sure you're good? And the patient's not even bleeding looking at that. So then you just start over again.
Okay. Brand new kit.
So, does anybody have any questions about MST? So we went over our training objectives essentially, right? We defined MST. We looked at the equipment that we used. We did familiarization with the ultrasound machine. We did a review of the anatomy, and then we actually did the simulation of actually using the introducer and the MST technique. Cool. So now you guys are ready. Let's go start sticking patients. You ready?
Let's do it.
All right. It's on. Thank you very much for your attention and time.